Hello and welcome to another episode of This Week in Hearing. I'm Brian Taylor, and today our topic is healthy hearing, healthy aging, and the 5M's of geriatric care. And with me to discuss this important topic today is Dr. Steve Huart. Steve is an audiologist at the Rocky Mountain Regional VA Medical Center, and Steve and I have known each other for a long time. I really respect his thoughts and his opinions on all aspects of audiology, and we're really great and we're really lucky to have him with us today. So welcome to the broadcast, Steve.
Thanks, Brian. Glad to be here. Appreciate the invitation and feelings mutual.
Yeah. So I wanted to have you on now for a while to talk about this topic of healthy hearing, healthy aging, and I think a good place to start. Maybe before we dive into the topic, just tell us a little bit about your background as an audiologist, some of the travels, where you've been, where you are now.
Well, I've been an audiologist since the 80s, so going on the fourth decade now. Most of my career has been clinical. I was trained at Mayo in Minnesota, then worked at a clinic in Wisconsin for about 10 years before I returned to Mayo. Worked there for another 10 years, then did a brief stint in the industry, working, as you well know, with Amplifon for a little while, and then for Cochlear for a couple of years as kind of an educator, talking to hearing aid audiologists about what would be a good cochlear implant candidate. And after a few years in industry, I decided I missed the clinic and had the opportunity to join the VA down in Tucson. And I am a Navy vet, so the opportunity to be a veteran, serving veterans, and back in the clinic was really appealing to me. So that's what I've been doing for about the last 13 years now.
Well, great. On behalf of everybody at This Week in Hearing, thank you for your service. And right now you're an audiologist at the Rocky Mountain Regional VA, right?
Correct.
Okay. So let's dive in. I know this is a topic that's near and dear to you. Hearing, healthy aging. Tell us about those topics and how they fit together.
Sure. When you've been an audiologist as long as I have, the topic of healthy aging becomes more and more pertinent. So yeah, this is definitely near and dear to my heart. But healthy aging, I mean, that's a huge topic. Full textbooks and conferences are dedicated to that. So it's really hard to summarize that in a interview like this. But I've got some operational definitions that I like to use. First of all, healthy hearing is easy. The way I personally define that is just being able to hear well enough to, either with or without hearing aids or assistive technology, to actively participate in the activities that you need to do, and maybe even more important, in the activities that you want to do. So if you're actively engaged and your hearing doesn't prevent you from doing things, then that's healthy hearing. And healthy aging, obviously, is a lot harder to define. Again, I think if you can do the things that you need to do to take care of yourself, you can do the things that you enjoy doing in your life, then you're aging pretty well. But for purposes of this discussion, I think healthy aging is, again, just able to do the things that you need to do and want to do.
Yeah. And we'll make sure there's a schematic of this in the broadcast, but one of the ways that I visually try to demonstrate healthy aging is I have a picture of Tom Brady when he's 43 years old, and he's the same age of a quarterback named George Blanda, who was 43 years old in like 1970 when he set the record for the oldest quarterback to throw a touchdown pass in a playoff game. And Tom Brady looks like he's about 25, and George Blanda looks like he's about 65. Even though at the time of each picture, they're both 43 years old. So it kind of shows you, I think, the value people place in healthy aging today and the fact that they want to take care of themselves. So anyway, it's a hot topic either way. You hear a lot about it everywhere. So we're glad to have you here talking about it. And the other part of our title was the 5M's of geriatric care. So maybe so that we're all kind of grounded in the term geriatric, who is a geriatric and maybe what makes them different than other younger patients?
Geriatric. What is a geriatric question? All the tough ones today, Brian. You know, geriatrics is extremely difficult to define, just as you mentioned. You know, in today's or in the 60s or 70s, you might have called Tom Brady a geriatric. In the year 2023, not quite so much. You know, I'm the Merck manual has an interesting definition of geriatrics, and they state right out that it is not easy to define the group precisely. And they suggest that people prefer the term older over elderly. Well, when I read articles now, they talk about older adults over 65 and having crossed that bridge. I don't particularly like older or elderly. So ageism is kind of a hot topic right now. Mm-hmm. And, we need to be careful about having these prejudices or preconceived notions of who's old and what is geriatrics. There really is no set age for a geriatric patient. Like you just said, Brady versus Branda. Thank you. Branda or Banda?
Blanda. Brady versus Blanda. Yeah.
Blanda. You know, I like the mountain bike, and because I live in Colorado and I don't hit the trails now like I did before. But I hope that when I'm 80, I'm still, at least if not, I'm able to mountain bike. I can still go hiking. So, you know, what's old and what's geriatric, it depends again on what you're able to do. Yeah. Another thing that in the Merck manual that they talk about, the definition is that it really is not a function of age as much as it is of health status. A lot of your listeners are probably familiar with the PACE program. PACE stands for Program of All-Inclusive Care of the Elderly. And if you're 55 years or older, but qualify for nursing home care level of care, then you're considered a geriatric patient and you can participate in the PACE program. So, you know, you can be 55 or you can be 105, and it depends on how you're doing or how well you're aging as to whether or not you would be considered a geriatric patient.
Yeah, I think what I hear you saying, Steve, is that it's not about chronological age, it's more about functional status.
Yeah, absolutely.
Yeah.
So and of course, no two people are the same. So it does depend a lot on what you do and how well you have aged and what your overall health status is.
Mm-hmm. That brings me to the next topic that I want to talk to you about, and this is something that I know you've talked about, and I've seen it written about. The one article that comes to mind was written by Barbara Weinstein a year or two ago about the geriatric 5M's. So maybe before you tell us about each of those M's, where does this concept come from?
That article you reference is a great one. That was in 2021, as a matter of fact. Barbara Weinstein did that article, and I would encourage anybody listening today to track that down. Just Google Weinstein and geriatric 5M's, and it'd probably come up. As far as I can tell from literature, Brian, geriatric 5M's came around, and they were introduced in about 2017 by a group of geriatricians. Dr. Tanetti is a geriatrician who's in charge of, or she's at Yale University, and a couple of guys out of Canada named Molnar and Wang. And they introduced the concept at a geriatric conference in Canada at the time. And they define it as a framework for caring for older adults that maps to the current core competencies in geriatrics. So what they were trying to do is come up with something that's easy to remember and kind of repackages what they called the geriatric giants, the things that are important when you're providing healthcare to an older population. And they go on to talk about it in a little more detail, that it's something that's simply conveyed to the 5M's are so people like us, people who are not in the geriatric field, understand a little bit more about what geriatricians do, what's important to the population that they serve, and what they bring to the table, and the things that they focus on when they're treating older adults.
Well, what's interesting, I didn't realize it was 2017. It's relatively new.
It's very new, yeah.
Yeah, so it's good to talk about it. So tell us about the 5M's. What is each of the 5M's, if you could describe them for us?
Sure. Before I do that, though, you're right about being new. I actually talked to a group of clinicians at the Rocky Mountain Geriatrics conference that was held here in Denver at the end of last year. And the first question I asked was, how many of you are familiar with the 5M's? And a lot of people were not.
That's why we have you on the broadcast.
Yeah, I think it's really applicable. I think it's very timely for us now. Now that you can buy hearing aids online and do a hearing test on your cell phone, we have to find things that make us relevant anymore.
Exactly.
And I think the 5M's is really fits into that model very nicely. So there are five of them, and the first one is mind, mobility, medications, multi-complexity, and what matters most. And they're fairly self-explanatory. The mind is all about cognition, mentation, dementia, delirium, depression, things like that. And what makes it important to us is, cognition and how hearing relates to cognition and the correlation between cognitive decline and hearing. So it's really easy for an audiologist when talking about the 5M's to plug themselves into that M, that mind, the mind M. And the next one's mobility. So of course that talks about gait and balance and preventing falls. And clearly, there are a lot of audiologists, maybe some listening today, who are vestibular specialists. So it's easy. Again, it's easy for an audiologist to start talking to people about balance and hearing and how the two are related. And I think as audiologists, right away when we talk about balance, we start thinking of the vestibular system. One of the things I try to emphasize when I'm talking to other providers who really don't want to get that deep into the weeds about the anatomy and physiology of the semicircular canals and how that affects balance is the basics, how hearing affects balance, how people, if they're concentrating, if they're working harder to hear, they're not paying attention to their surroundings, and they can step off of a sidewalk and break a leg. I was working with a geropsychologist here at the VA, and I was talking about this topic, and she said, well, what if somebody's got a dog and the dog walks up behind them and they can't hear the dog and they trip over the dog? Beautiful. This woman gets it. It's fun when you work with another specialist who goes, oh yeah, I see the connection. Medications, the third M, medications is huge. We did an analysis. We did a chart review here at the VA, and I'll talk a little bit more about that in a minute. Over 600 charts, and geriatric patients are on a lot of medications. And there's a lot of things we don't know. As I talk to other pharmacists about this, we know as audiologists what medications are ototoxic, but when you start talking about people taking 5, 10, 15, 20 different medications, nobody really knows how they interact to affect their hearing, certainly their cognition and their understanding. And even more fundamental than that, think about your grandma or your grandpa sitting in a doctor's office, and the doctor's saying, okay, you have to take this medication in the morning, you have to take this one with food, you have to take this one twice a day, break this one in half and mix it up with food, take this one on an empty stomach. And if there's a hearing loss, that's huge. And there's plenty of data out there that talks about medication errors and the negative things that happen to people in hospitals and medical settings because of a communication breakdown. And of course, the biggest communication breakdown is hearing. So that's an easy one for audiologists to fit right into. Multi-complexity, geriatric patients are older. They have a whole host of medical issues that they have to deal with. So that's one of the reasons patients become geriatric patients. See a geriatric specialty is because they're no longer the routine, let's go to your family doctor and get an annual checkup. They've got all kinds of different system problems. So it takes somebody with special training in geriatrics to really provide the best care for that population. And so hearing loss can contribute to or even cause some of those multi-complexity comorbidities that we talk about. And again, you start talking to physicians or psychologists or physical therapists about the complex conditions that their patients have and how hearing contributes to that. And it's a good place for audiologists to be. But the one I like the most is what matters most. It's the last of the 5M's. And we do a lot of interdisciplinary activities here. And anytime we get the chance, the audiology team that participates in that, to talk about these geriatric patients, everybody focuses on the big things: controlling pain, hypertension, diabetes, and really hearing loss kind of falls off the radar screen a little bit. It's just not the most important thing. But when you're talking about these people that are 80, 90 years old, they're not doing the things that they used to do. They don't really have a whole lot to look forward to, at the risk of sounding blunt. But what matters most to a lot of these people, if you really sit down and ask them, is that they like to do things like watch TV. They like to watch their ball games. They like to watch their sporting events. They like to visit with their family. They like to talk to their family on the phone. If they're still able, they go to the Elks Club or the VFW or the Legion and they socialize. So really the last quality of life enhancement that a lot of people have at the end of life is their ability to communicate with people. So any chance I get to talk about the 5M's, I really emphasize that one. From an audiologist perspective, I think it's probably the most important of the 5M's.
Yeah, no, that's well said. So as a follow-up, I'm kind of curious, how do you incorporate, how do you fold into, or how do you apply the 5M's in your practice now? I'm curious, not only with patients, but also maybe you've already mentioned some of the other medical specialists that you might collaborate with. How do you fold it into communication with other medical specialties?
That's where most of, at least my energy goes. Since I got involved with the GRECC program here at the VA, that's where I spend a lot of my, that's where I live. I spend a lot of my time and energy working with people who are treating geriatric patients. And the way we use the 5M's is we focus on the hearing loss comorbidities. And AAA has a great handout. I don't know if anybody's seen it. You can get it off the AAA website, and it lists the 7 comorbidities of adult hearing loss. And it is beautiful. It's a nice little infographic. It's got a nice picture, and on the back of it there are references, so it's evidence-based. But the neat thing about that is when I'm talking about comorbidities like cardiovascular disease, chronic kidney disease, diabetes, and cancer, now I can talk to healthcare specialists in their language. I don't have to try to impress upon them. You know, no matter how objective I try to be when I'm talking about hearing loss and how important it is, other people go, yeah, well, you're an audiologist. That's like asking a lawyer if you need an attorney. So I really try to put it in language that's important to them. You know, if you're an endocrinologist and you're treating people with diabetes, and I can say, well, the CDC recommends that diabetics get a hearing test every year, then now I've got their attention. Oh, I didn't know that, really. Yeah, hearing loss is that common in people with diabetes? Yeah, it is. So to me, the beauty of the 5M's is the fact that we can tie it to each one of those comorbidities. Like I said, cardiovascular disease, cancer, cancer, obviously chemotherapeutic agents, but again, quality of life. These people are sick. They want to be able to hear their healthcare providers. They want to be able to hear their family members. Diabetes, it's just a real nice symbiosis between.
Yeah, so it makes it easier, I think, to communicate with other medical specialties when you have those 5M's sort of as a framework, it sounds like.
Right.
Yeah.
And people,
you mentioned,
people like it when you talk to them in their own language, right?
Right.
So if I'm talking to an internal medicine specialist about hearing loss, that's not their language. If I'm talking to an internal medicine specialist about fall risks and cardiovascular disease and diabetes and how hearing loss connects to that, I'm speaking to them in their language. They get that, and they're more likely to pay attention.
Yeah, we'll try to link that handout that you mentioned from AAA in the notes here, so people can.
Yeah, anytime I go speak, if I have an opportunity to sit down with a group of healthcare providers, whether they're physicians, nurses eat this stuff up, psychologists, physical therapists, anything outside of audiology, I always bring that infographic from AAA, and that's my handout. I let them take that with them when they go.
Good to know. You mentioned something called the GRECC, GRECC, I think. I know I've seen that in some of your presentations. So tell us more about the GRECC. What is it, and what have you learned from it?
Good question. GRECC is an acronym. It stands for the Geriatric Research, Education, and Clinical Centers. And if you're in the VA and you don't know about the GRECC, maybe you should, but not all VAs have GRECCs. There are 20 of them around the country, but I think it's really one of the feathers in our cap. It's just an excellent program. Came in 1975, Congress actually dictated that this GRECC there should be GRECCs, and they're established to improve healthcare and for older veterans. And there's three missions: build new knowledge, improve healthcare for older veterans, and provide training and education. And I'm not a hardcore researcher. I'm a clinician. I have been my whole career, and I'm not creative and smart enough to come up with a whole lot of innovative practice models. But providing training and education, I can wrap my head around because I've been a clinician for a long time, got a lot of experience, and I can share that with people. So I really focus on that third mission of the GRECC. And like I said, there are 20 of them around the country, and each GRECC by mandate has to be affiliated with an academic institution. So here in Colorado, the University of Colorado is just across the road. Mm-hmm. So we collaborate, and research projects go back and forth, and patients go back and forth, and providers go back and forth. And it's just wonderful. I didn't know what GRECC was before I got involved with the VA, and as a matter of fact, didn't know what the GRECC was after I was in the VA until 5 years ago. Again, by mandate, GRECCs have to have allied health representation so that they can train specialists on the broad range of services that are available for older veterans and improve the quality of care. So somebody reached out to me and said, hey, the Office of Academic Affiliations funds some of our trainees in the VA. And somebody reached out to me and said, hey, our GRECC has money for a student, and we need allied health professions represented in the GRECC. So would audiology be interested in participating? And so, like I said, that was 5 years ago. And it's since then, it's just great because here, each VA is different. And there's a GRECC website that you can go on, and you can look at each one of the different GRECCs. So depending on where you live, if you want to explore it, you can find one close to home. But here we have geriatric fellows who are part of the program. We have geropsychologists, physical therapists, speech pathologists, pharmacists, and social workers, and us. So there's 7 different specialties. And there are all kinds of different activities that go on throughout the course of the week and the year. There are lectures every Friday. There are interdisciplinary case conferences, which are kind of like grand rounds. And those are a lot of fun because all these different trainees in different disciplines come together and sit around a table. And the directors, like I pick a case for audiology, and the senior clinician in pharmacy or geriatrics will pick a case for their specialty. And then we'll take turns presenting those cases. And each one of the individual discipline trainees has to present that information. And they don't know anything, a social worker doesn't know anything about audiologists. So when they have to present audiology information, it forces people to ask questions. And it's just a really neat learning experience. Yeah.
If I'm a non-VA audiologist and I wanted to look at some of the publications from the GRECC or some of the research from the GRECC, would I be able to find that online?
Yeah, just Google GRECC. Yeah,
well,
and a lot of the people are not. Sorry, Brian.
GRECC, right?
Right. Yeah.
Go ahead.
A lot of the people are not, because of the university affiliations, so it's not limited to VA, and it's really not at all audiology specific. In fact, in 2021, GRECCs trained over 2,000 trainees, and those were physicians, residents, fellows, psychiatry residents, psychology residents, and all the other healthcare disciplines. And then over 500 allied health professional trainees as well. So, I mean, it really is a multi-specialty, interdisciplinary project.
Very nice. Well, now that we've been chatting now for going on a half an hour, my last question to you, Steve, is how does an audiologist maybe an audiologist that's not affiliated with the VA or government services, what would your recommendation be for them to kind of apply the geriatric 5M's to raise their own standard of care with this population? What's your advice to them?
Easy. I'd learn what the 5M's are. I mean, it's pretty easy. If you get into the literature, there's a little mnemonic device. It's the hand. It's got mind, mobility, medication, multi-complexity, and what matters most. So, I mean, it's pretty easy to memorize those 5. And then if you don't have to memorize the 7 comorbidities, but get that handout, keep that sucker folded up in your pocket. And whenever you have an opportunity to talk to healthcare providers, find the comorbidity that's in their wheelhouse so you can capture their interest and then relate it back to the 5M's and then start to talk about how hearing can, or what you bring to the table. It's all about interdisciplinary collaboration and, helping provide the best care. And most people get it. Every once in a while, you'll run up against somebody who says, I've had physicians tell me, well, I'm not going to look in the ears because I don't have enough time. Well, you win a few, you lose a few.
Right.
But most people get it. And when you break it down and talk about things that are important, and the 5M's are so simple. How can you argue with that? How can you argue that cognition's not important or mobility? If you're not mobile, you can't do anything, and all the things we talked about.
Yeah, and it's great how it all fits together and how hearing is such an important part of it.
Yeah, it really does. What I'd really like to see, Brian, when I have the opportunity, and since you asked this, almost all of the specialties that I work with have some kind of a certification in geriatrics. Audiology doesn't. Physical therapy does. Medicine does, of course, geriatricians, psychology, social work. So many specialists have a certification in geriatrics. I'd love to see audiology come up with something like that, like board certification for cochlear implants, board certification for pediatrics. A board certification for geriatrics makes so much sense to me, since so much of what we do is with that population.
Yeah, it sounds like a call to action. So if there's any AAA board members or advocates out there, why not have a certification for geriatrics? I mean, it is the largest population that we see, relative to pediatrics and others. So why not? It would make sense.
Great.
And, especially in light of OTC and those kinds of things, why not have a way to stand apart with a specialty? So that's great advice. Maybe we can get some attention by having you on the broadcast here to talk about the 5M's and how they relate to seeing geriatric patients. So Steve Huart, audiologist at the VA Medical Center in Colorado. Thanks for taking the time to be with us. I appreciate it.
Thanks, Brian. Thanks for having me.